Okay, so we begin with our discussion of the blood. This red blood. Is blood red all the time? No. Well, blood is not red all the time because there is red blood and blue blood. Actually, these two colors we discussed in lab, these were not made just by picking colors. They were actually based on histological examination of the blood. So we do have red blood and we do have blue blood. Blue blood is deoxygenated toxic blood that is full of. Can you guys settle down, please? So we do have red blood and we do have blue blood. Blue blood is deoxygenated blood that is full of toxic waste, and red blood is oxygenated blood that is full of oxygen and nutrients. So in order for us to transport this blood, we're gonna need a pump, and the pump is the heart. We began the course by discussing the different types of gradients. We have concentration gradient, we have electrical gradient, we have pressure gradient, and we have chemical gradients. So in order for a fluid to move from an area of a high pressure to an area of a low pressure, we gonna need it to have a pump. So now this blood, before we study the dynamics of how this blood flows through our conduits, from our heart pump through these blood vessels to the lung to be oxygenated, to the tissue to nourish and perfuse the tissue, let's examine what is the makeup of blood. So on the lab that you guys did on Tuesday, that was a Friday schedule. You learned that this blood, when put in a centrifuge, can be separated into three different fractions. The most dense, the heaviest one is the bottom layer, and that is the erythrocytes. The erythrocytes, these are the red blood cells. These red blood cells are biconcave. They have a depression that is on both sides of the red blood cell. And this is a thermodynamically favorable structure for the red blood cell. It needs to be biconcave because that enables it to maneuver through our blood vessels. That's why sickle cell anemia is a disease that is caused by a mutation. So, in order for us to have a biconcave red blood cell, we need to have DNA being transcribed into mRNA and the mRNA being translated into the proper sequence of amino acids. Now, the problem is for a healthy, normal red blood cell, we needed to have the amino acid known as glutamic acid, GLU. But due to the mutation, we end up with an amino acid that is known as VAL, valine, and that causes the shape, the structure of our red blood cell from being biconcave. Why do they call it biconcave? Because it is depressed from both sides. It causes it to go from being biconcave into being sickle. It has two edges. So this is a sickle red blood cell. This sickle red blood cell will be trapped in the spleen. So the spleen is the graveyard of red blood cell. What is the graveyard of RBCs? The spleen. So that's the site where old worn out red blood cells get damaged. And they get damaged because they are forced to pass through really tiny sinusoids. Sinusoids. These really tiny sinusoids are passageways that test the red blood cell's ability to maneuver inside the spleen. So the really young and healthy red blood cells will pass fine through the sinusoids, while the really old or sickle cells are going to get trapped. And when they get trapped, there are macrophages. There are macrophages, and these there are macrophages, and these macrophages are going to damage and remove and destroy all of the worn out and old red blood cell. So a single drop of blood contains millions of red blood cells. And our blood is not only made up of red blood cells, that is the heaviest bottommost layer. That is the erythrocytes. These are the red blood cells. And they make up about 45% of our blood. So by mass, the red blood cell is about 45% of our blood. Right on top of it, right on the top of red blood cell, you have a small fraction that is even less than 1%. The red blood cell is 45% of your blood, while there is a one layer on top of it known as the buffy coat. The buffy coat. This buffy coat is your platelets, and your white blood cells. So you need to know that. You need to know that red blood cells are known as erythrocytes, and they make up about 45% of our blood. And you need to know that the buffy coat is the next layer on top of the erythrocytes, and that's about 1% or less, and that is known as the buffy yellow creamy coat. Yes.
So, is it true for the erythrocytes that 40 to 50% is males and then 36 to 44 is in females?
Yeah, so there is inherent variability. So females have more fat tissue in their body. That's why they have less water content in their structure compared to men. So yes, these changes are between, men to women. They exist. We said that anatomically we are not identical, but the ratios are the same. So what you need to know is that red blood cells make up about 45% of blood. 1% or less is your platelets, and your white blood cells, WBCs. Platelets have another name, and these are your thrombocytes. That's why when you are injured, a thrombus is made. A thrombus is made to cover for that injury site. And then you have white blood cells. White blood cells, these are known as leukocytes. These are known as leukocytes. These leukocytes, these are the cells that defend you. These are the cells that defend you from microbial infections. And those two types of cells, platelets and white blood cells, thrombocytes and leukocytes, they make up about even less than 1% of your blood. Well, if 1% is your buffy coat, this is known as the buffy yellow creamy coat. Buffy yellow creamy coat. This buffy yellow creamy coat makes about 1% of the blood, and 45% is the erythrocytes. The rest is 55%, and that is plasma. 55% of the blood is plasma. So plasma has a lot of water, H2O, and has a lot of electrolytes, has a lot of proteins, and has a lot water, electrolytes, proteins, and hormones, and so on. Okay, so that's the concentration we talked about. Plasma is made up of water, as where my mouse is pointing. So the top layer, you see we have three fractions. The red one, and in the middle, they have it in white, but it's actually yellowish. And you have plasma that is a clear solution that is a little bit like brownish or beige color. So that is about 55%. So that's made up of water, proteins, nutrients, and hormones, and so on. The buffy coat is the middle layer that makes up about 1% of our blood, And below that is your red blood cell content, the erythrocyte, that's about 45%, which is the hematocrit. That is the hematocrit. A patient who's suffering from anemia, anemia is low red blood cell count. Just the red blood cell count is low, and they will have a depressed or low level hematocrit. And as you mentioned, females have red blood cell content. So now I don't need to say red blood cells or erythrocytes. If I say hematocrit, that represents the amount of red blood cells that are found in my blood. So the hematocrit for males is from 37 to 47%. And hematocrit for females is 42 to 55%. So we don't want too little blood. That is known as anemia. And too much blood, too much hematocrit. That is known as polycythemia. So the cellular elements of the blood include a vast number of erythrocytes and comparatively fewer leukocytes and platelets. So the plasma is the fluid in which the formed elements are suspended. So you have your formed or preformed elements, and a sample of blood is spun in a centrifuge. We talked about that, and that reveals that the plasma is the lightest component. So the plasma is always at the top because it is the lightest, and the hematocrit is at the bottom because it is the most dense. It is the most dense. So why do we not want too little red blood cell? Why do we not want too much red blood cell? What is the problem with having too little red blood cell? What is the problem? Why do we just have to have a normal range, homeostatic range, 42 to 52% males, 37 to 47% females? Why do we not want this deviation? Why not the more the better? You know, the more you got $100, you get paid 200, the more the better. Why is polycythemia dangerous? So what's the clinical example? What is that going to lead to? Too much blood. What is that going to cause? How? So that's going to increase the cardiac output. That's going to increase the blood pressure. Yes, true, but that's not exactly what happens. It does lead to a heart attack, but not because too much blood is rushing to the heart. Actually, the blood gets really thick. It becomes hypercoagulable. So there's so many red blood cells, especially for the smoker, smoking the cigarette, smoking the weed, smoking the vape. Those are gonna cause your red blood cells to be damaged. So your bone marrow is the computer that makes a supply red blood cell. So now your red blood cells are there, but they are useless. So your red bone marrow is gonna keep making more and more red blood cells, and your blood is gonna become so thick and so sticky, so gooey, so like honey, and then it's not gonna move fast. It's gonna move, yeah, it's gonna clump. Yeah, it's gonna become really sticky. It's not gonna move in the blood vessels, and you cannot deliver it to the tissue. It's not even carrying oxygen, and that's gonna cause like stroke. It's gonna cause like this blood clot. It's gonna make blood clots. Enlargement of the organs. Enlargement of the organs. Yeah, enlargement of the heart because the heart is trying to pump this blood that is not moving, trying to push it because the blood is so thick. What about anemia? Why is anemia dangerous? Doesn't transport oxygen to the other lungs. Exactly. So there is a drop of oxygen supply. That's called hypoxemia or hypoxia. There's a drop in oxygen supply. Hypoxemia is a drop in oxygen level in the blood. Hypoxia is an overall drop in oxygen saturation within the tissue. But both of them are caused by anemia, especially in young females who are menstruating, but they don't take the iron pill. Young menstruating females in the reproductive age have to take the iron pills because iron is very important to make the hemoglobin. So this figure we talked about, it shows you, what are the formed elements and how much do they occupy in the blood. You see that the plasma represents about 46 to 63% of the blood, and the formed elements, these are your leukocytes, your erythrocytes, and your platelets. These guys make up about your buffy coat plus your hematocrit. And to show you that the major protein in plasma is albumin. You really need to know that because albumin is very important to maintain osmotic concentration. So patients who have kidney failure and in their kidneys they are leaking albumin. So when albumin leaves their body, there is a drop in the osmotic balance. So there is hypoosmolar blood, and that causes the water to move away from the blood into the tissue because the osmotic balance was maintained with albumin. So the water was in equilibrium between the extracellular space and the intracellular space due to the presence of albumin in the blood. Now, when albumin left the blood, water is gonna follow albumin to the urine, and water is gonna leave the blood, go into the tissue because now the tissue has more solute than blood. So now the water is going to leave the blood into the tissue. That's going to cause edema. There are globulin proteins. These globulin proteins are very important for the immune system because globulin proteins, these are the antibodies. These are the very important antibodies that defend you through this is known as B lymphocytes. B lymphocytes send antibodies. So in the immune system, we have T cells and B cells. T cells, they're like soldiers. They have weapons, they have rifles. But their weapons, they're not actually guns or rifles. Their weapons are granzymes, proteolytic enzymes, acid, reactive oxidative species, degradative enzymes. So these enzymes are destroying the macro, these are destroying the infectious microbe directly. But the B lymphocytes, they're like helicopters or Air Force jets who throw the missiles at the target. So the B lymphocytes, they do not throw granzymes. They do not throw degradative enzymes. They do not throw acid. They do not throw reactive oxidative species at this microbe, this infectious microbe. They throw antibodies. And the antibodies are like missiles, like weapons. They destroy, they damage your microbial infective organisms. So this antibodies are made of what kind of protein is known as globulin. Fibrinogen, when you end with nogen, that means it's inactive. It has to be converted from fibrinogen into fibrin. So hormones and enzymes are also we have enzymes have to be proteins. Remember we said sodium potassium ATPase? That's an enzyme because it hydrolyzes ATP in order to send out sodium and bring in potassium. Red blood cells to transport oxygen and to transport carbon dioxide. So what is that very important protein that is inside? What's that important enzyme that is inside your red blood cell and is important for delivering the oxygen to the tissue? So it's called hemoglobin. So hemoglobin has the name globin. So hemoglobin is made up of 4 subunits, 2 alpha subunits, and 2 beta subunits. And these subunits, each one of them has a heme or iron group. That iron group is able to bind oxygen. So it binds oxygen in the lung and transfer it to the tissue. And hemoglobin is also able to bind carbon dioxide in the tissue, transfer it back into the tissue and transfer it back into the lungs. Okay, so now if we want to get red blood cells, if we want to get white blood cells, well, these are cells, and cells come from other cells. Cells come from progenitor stem cells. You are here because your parents were there before you. Your parents are there because your grandparents. Your grandparents are there because your great grandparents. So every cell, cells don't come out of nowhere. Cells have to be coming from a source, stem cell. So if you see here, after the division, some cells remain stem cells, but you have your multipotent hematopoietic stem cells. These are the hemocytoplasms. These are the cells that begin the division to give us our myeloid and lymphoid lineages. So you have to appreciate that the remaining cell that goes down one of the two paths depending on the cytokines. So we have a multipotent hematopoietic stem cell. That multipotent hematopoietic stem cell has one of two fates. It can either return, you see the arrows pointing back. This arrow pointing back means that this stem cell is becoming a stem cell again. Or it can now become a precursor for one of two lineages. So stem cells can either go down one or two paths. They can either become lymphoid stem cell that will give us the T lymphocytes and the B lymphocyte we just talked about. Which one of these two utilizes antibodies? The B lymphocytes or the T lymphocytes? Hmm? Yeah, the B lymphocytes. You know, antibody B lymphocytes, B, antibodies, B lymphocytes. And T lymph, but in the end of the day, lymphocyte is a lymphocyte. It comes from what lineage? Lymphoid stem cell. The other type of lymphocyte is your natural killer cells. These are types of cells in your innate immunity. When you have an infection of a microbial infection, bacterial infection, fungal infection, viral infection, parasitic infection, you have a first line of defense. So if criminals come to New York City, the army is not going to come immediately. It's going to be the police because these are the ones who generally deal with crime, generally deal with invaders. Then, if they cannot solve the problem, then more specialized immune cells step in place, like these B lymphocytes and T lymphocytes. The same way the police officers. Police officers are so general. They respond to homicide, they respond to crime, they respond to thieves, they respond to jumping a turnstile, they respond to traffic violations. But when the problem gets bigger, then you have detectives. The detectives come for homicide, detectives come for robbery, detectives come for fraud, detectives come for arson. So that's the next phase. That's known as specific response. So in the beginning, these natural killer cells, they are types of lymphocytes that are general, while the T lymphocytes and B lymphocytes, they both are generalized, but these both are specific. The T lymphocytes and B lymphocytes are detectives, they are specific. They fight with antibodies like B lymphocytes or directly like T lymphocytes in specific phase. You had a question?
The T lymphocytes, they fight the decreated enzymes.
They fight the
Decreated enzymes.
degradative. They secrete degradative, so they can degrade their enemy. Degradative enzymes, proteolytic enzymes, and acid and reactive oxidative species. These are all weapons, lysosomal enzymes. Like the police officer has a gun, a taser, and a baton. They have everything to use. So they need all the weapons they need in order to fight the invaders. On the other lineage, you have your myeloid stem cells, your myeloid. These are not lymphoid. So who comes out of the myeloid stem cells? These are your megakaryoblast. Please remember that. The megakaryoblast is where your platelets come from. So the myeloid stem cell give you megakaryoblast, then the megakaryoblast give you platelets. The myeloid cells, they can give you pre-erythroblast, and from the name erythro. What is that going to give you? An erythrocyte. Then you have a myeloblast. The myeloblast is going to give you your neutrophils for the bacteria to fight the bacteria, your basophils to fight your viruses and parasites, and so are the eosinophils. Basophils are called basophils because they stain basic, violet. And you have your monoblasts. These monoblasts, they give you your monocytes. There's an arrow missing here, but it's very important for you to know that what do monocytes give you? Does it end here? Do the monoblasts end here in the monocytes? No, they do not end in the monocytes. They do not end in the monocyte. They give the monoblast, they have the monocytes, and then the monocytes, they give macrophages. Okay, hematopoietic stem cells of the bone marrow. So hematopoiesis is the pre-proliferation and differentiation of these are all known as the formed element. That's very important. These are known as the formed elements. What are the formed elements? It is the guys who come out of these two lineages, your lymphoid stem cell and your myeloid stem cell. Lymphoid and myeloid stem cell. Okay, summary of formed elements. Summary of formed elements. So these are our formed elements. We talked about the erythrocytes and the leukocytes and the platelets. What's another name for the red blood cells? Erythrocytes. What's another name for white blood cells? I'm sorry? Leukocytes. Okay, leukocytes. At least when you see it in the multiple choice, you can find it. Unless I put leukocyte, lycocyte, leukocytes, then I'm gonna get you on that one. You know, I did this in the other school. They were very confused. They just thought that we need to know the first three letters and just like leukocytes. Then I started putting leukocyte, then they got it wrong. And then platelets. What do we call platelets? They have another name. They have their own name too. I'm sorry? Thrombocytes. Excellent. Now, megakaryocytes. Give me who? Do megakaryocytes give me erythrocytes or leukocytes or platelets? Excellent. That's very important. Okay, we talked about being biconcave. Why do they call it biconcave? They are depressed on both sides. So they look like a biconcave disc that is discoidal shape. This shape optimizes the ratio of the surface area to the volume. So it facilitates gas exchange. It also enables them to fold up as they move through the narrow blood vessels. Okay, that is, now who is that? This is very important. That's my hemoglobin. How many subunits do you see here? How many subunits? One with its heme. You see the heme group? One beta, two betas. One beta with a heme, two beta with a heme. You see the beta chain one with a heme, beta chain two with a heme, alpha chain one with the heme, and alpha chain two with the heme. Who binds in this heme? It is oxygen. So how many subunits do I have for hemoglobin? Four subunits. Each subunit has a heme. On each heme, what sits at the center of the heme? Iron. Excellent. You see Fe2 plus. That's iron. Ferrous iron. Fe plus 2. Fe plus 3, that's known as ferric. Ferric does not bind oxygen. It is ferrous iron, Fe plus 2. So that binds oxygen, and that causes that binds oxygen and that saturates hemoglobin with oxygen. So this diagram is very important. So if we examine this diagram, we see that the erythrocyte has a life cycle that begins in the bone marrow. When we were doing the lab, remember we said that if you slice an egg in half, only then, sagittally, you'll be able to tell that there is a yellow yolk in the middle. So if we do the same thing to bone, we slice bone in half. How many colors in the middle are we going to be able to see? Two. What are the two colors? Red and yellow. Excellent. Now this red. Why is it red? Because it makes blood. So the life cycle begins from the red bone marrow and it ends at the graveyard. What is the graveyard of the red blood cells? The spleen. Excellent. So erythrocytes are produced in the bone marrow and sent to the circulation. At the end of their life cycle, what is the life cycle of a red blood cell typically? They are destroyed by macrophages and, and components are recycled. In the these are known as sinus histocytes. These sinus histocytes, these are the macrophages that are found inside those little tight tunnels inside the spleen. What is the typical life cycle for a red blood cell? 120 days. Excellent. So 120 days divided by 30. How much is that? 4 months. That's why a diabetic patient needs to get their blood checked 3 times. 3 times every 4 months, 3 times a year, every 4 months, 3 times a year. Why? Because at the end of each 3 months, the red blood cells get damaged. So now we want to see the red blood cells. Do they have a lot of sugar? Are they glycosylated or not? So erythrocytes are produced in the bone marrow and sent into the circulation at the end of their life cycle. They are destroyed by macrophages and their components are recycled. So that shows you hematopoiesis of the erythrocytes begins in the hematopoietic bone marrow. You see? And then you have stem cells, and the stem cells will give you erythroblasts and the erythroblasts are going to give you the reticulocytes. Then reticulocytes are released into the bloodstream where they mature into mature erythrocytes, which circulate for an average of 120 days, like Jamie said. So the old, worn out, and damaged erythrocytes are phagocytosed by macrophages in the bone marrow, the liver, and the spleen. So the globin protein portion of the hemoglobin is metabolized, broken down, recycled to give us globin amino acids, while the heme part is going to be broken down into, you see the heme group is going to be converted into biliverdin, then a bilirubin that's going to be used for bile, and then the iron is going to be converted into ferritin that's going to help restore iron homeostasis. So sickle cell anemia, we talked about sickle cell anemia. You see how they get sickle? They have these two pointy edges due to a mutation. A mutation in what amino acid? What were we supposed to have and what did we end up getting? We ended up getting sickle cells, but because of a mutation. The mutation was I was supposed to get which amino acid, and I didn't. I ended up with another amino acid. That's why I got sickle. If I had a good amino acid, I would have been biconcave discoidal. But because I have I have the wrong amino acid, now I have sickle cell. What is the amino acid that I should have got to be discoided and unrounded and discoidal? Excellent. So glutamate is the amino acid that if I gotten it, my amino acid glutamate would have made my red blood cell rounded and discoidal. But because due to a mutation, a mistake in the mRNA transcription, I no longer have glutamic acid. What do I have now? You have a sickle cell because of which amino acid? It's written up there. Glue for glutamate, glutamic acid. And the other one is, see three letters, GLU and VAL. You see the VAL. What's the name of VAL? Valine. Excellent. You Googled that one? Yeah. Very good. Nice. Good job. At least you got it. Valine. Okay, so leukocytes approach, you see, that's the site of damage. You see this injury here? You see this fissure? You see this ulceration? Around it, you have necrotic debris. You have damaged cellular structure. And the damage, they're falling apart. And when they're falling apart, this damage is leading to the accumulation, is leading to the accumulation and the recruitment of the neutrophils. So the neutrophils are going to come. You see how they squeeze inward? That's your blood vessel. So in your blood vessel, you have your neutrophil and your xenophils squeezing through these gaps known as interendothelial gaps. These are known as interendothelial cleft. So from your red blood cell, because you know the white blood cells, they circulate inside the blood vessel. So they squeeze out and they travel. You see how they are? They travel and they swallow and they engulf and they swallow all of the microbes and they swallow all the dead damaged cells. Remove, clean that, remove out of the way so this injury now could be healed. It could be healed. That's a neutrophil. A neutrophil has small granules, and the granule means that they have a lot of enzymes, proteolytic degradative enzymes. Then you have eosinophils. These eosinophils are full. These are full of acid in order to destroy the parasites. So all of these guys, they have granule. These granules are a type of weapon. Inside the granule, you have your acid. Inside this circle, inside this bubble, you have your acid, you have your reactive oxidative species, and you have your damaging, you have these dangerous lysosomal enzymes. Platelets. Platelets are derived from cells called megakaryocytes. These are derived from cells known as megakaryocytes. So the megakaryocytes are made up of myeloid stem cells. You have megakaryoblast and megakaryocytes. So you saw that you begin with myeloid stem cell, and myeloid stem cell would be converted into megakaryoblast, and the megakaryoblast will give you the megakaryocyte. And the megakaryocyte is the precursor for our platelets. Okay, so that shows us our basophil. Why do they call the basophil basophil? Because they stain basic. And eosinophils, they're called eosinophils because they stain acidic. They stain acidic. And these are monocytes. Monocytes are cells that differentiate to give me macrophages. These are cells that differentiate to give me the macrophages. What are the monocytes? I'm going to ask you about that on the next quiz. So you have to know that the megakaryocytes are the precursors for platelets. And the monocytes are the precursors for macrophages, macro, because they are big swallowers. And lymphocytes, there are two types of lymphocytes, the T lymphocytes and the B lymphocytes. Hemostasis is when an injury to a blood vessel initiates the process of homeostasis. So you would have blood clotting, involving three steps. First, you would have vascular spasm that constrict the flow of the blood, and next you would have a platelet plug. So the platelet plug would form to temporarily seal small openings in the vessel, and then you would have coagulation. The coagulation would enable the repair of the vessel wall once the leakage of the blood has stopped. The synthesis of fibrin in the blood. So fibrin is what we get after we convert fibrinogen into fibrin. So we cleave the inogen part, converting fibrinogen into fibrin. Then the active fibrin is going to help us make a thrombus. That's why you have this very important enzyme thrombin. You see where my mouse is? This enzyme is very important. You see all of these pathways. You have an intrinsic pathway. You see my mouse. See, you have intrinsic pathway and extrinsic pathway. Intrinsic pathway means the damage started internally. That's why they call it intrinsic pathway, because you have been damaged on the inside. Extrinsic pathway, that is when the damage came from the outside, stab wound, a trauma. Then both of them, in the end, they have to converge at factor 10. X is 10. Remember, X is 10. At factor 10, you would have this is the most important step in the cascade, and that is to convert prothrombin into thrombin. Converting prothrombin into thrombin. When you have thrombin, you know from the name, thrombus, that's a blood clot. When you have thrombin, that's an enzyme. So not all the enzymes end with ACE, hydrolase, sodium potassium ATPase, peroxidase, maltase. They don't always end with ACE. You have thrombin, that's an enzyme. Thrombus is when you have a blood clot. But thrombin is the enzyme that makes the thrombus. And what does thrombin do? You see fibrinogen is going to be converted into fibrin. And then when fibrinogen gets converted into thrombin, that's when thrombin converts fibrinogen into fibrin, fibrin is going to cause a meshwork. It's going to cause blood platelet plug formation. It's going to cause a platelet plug formation, forming a thrombus. Okay, erythroblastosis fetalis. That happens when a mother's immune system starts to inspect the red blood cells of the baby. We mentioned in lab that a baby has lungs, but they're not working. The baby is not breathing through his lungs. So the baby is sending his blood mixed up with the blood of the mom, and it goes into the lung. And when the mom breathes, she breathes both for herself and for her baby. And when she exhales, removing carbon dioxide for both, for herself and for her baby. Now, the problem is, these red blood cells, you know, they have glycocalyx, right? They have glycolipids and glycoproteins at the surface of the plasma membrane, or the cell membrane of red blood cell. Now that protein is different from the red blood cell of the mom. So the immune system of the mom, when scanning red blood cells, is going to say, these red blood cells, they are the mom's. These are all red blood cells. But those baby red blood cells, maybe they are bacterial. So it's going to destroy them. It's going to destroy them. Hold on. They're going to destroy them. So that's the problem. The baby now is not able to get oxygen because his mom's immune system is destroying his red blood cell, because the glycocalyx on the surface of the red blood cell of the baby is different than the glycocalyx of the surface of the red blood cell of the mom. So in order to solve that, they give the mom an injection known as an anti-D injection. This anti-D injection is able now, this anti-D injection is able to sensitize the immune system of the mom. So now when the immune system of the mom sees the red blood cells of the baby with their different glycocalyx, is not going to destroy them. And another thing you need to know is that the mom, let's say she is pregnant now, with this baby that she is pregnant with, if his red blood cells or glycocalyx is different from hers, if the baby is Rh positive and the mom is Rh negative, is she gonna destroy it immediately? No. The first birth will go unnoticed because your immune system has just now been sensitized. Now the immune system just realizes these are different glycocalyx from our red blood cells. These are different glycocalyx from our red blood cells. We need to be careful. So the next birth, the next pregnancy, when the mom is pregnant the next time, that is when the immune system begins the attack. So it's not on the first pregnancy. It is the first pregnancy that causes the awareness, the alarm, that the immune system is now making antibody, making anti-Rh antibodies. The next pregnancy is when the anti-Rh antibodies that have already been preformed from the first pregnancy, they are now ready to destroy red blood cells of the baby. Then when the mom is pregnant again, then the immune system sends antibodies to destroy the red blood cells of the baby, so the baby dies. So you have to understand that this issue is known as the RH factor. In the RH problem, it is who is destroying the other. So the baby is Rh positive, obviously. If the baby is Rh, this is the mom, this is the baby. If both are Rh positive, is she gonna destroy his red blood cell? No, because likes dissolve like. We've seen this with polar dissolve polar. We've seen this with lipid dissolving lipid. So when both are positive, nothing happens. When both are negative, will anything happen? No. But when the mom's positive, but the baby is negative, will she destroy it? No, will not destroy it, because she has already been sensitized. So she's used to Rh or no Rh. The problem is here. When the baby is Rh positive and the mom is not, she doesn't know, she's minus, she doesn't know Rh positive. That's when the immune system will say, you're not welcome here, you're plus, we are minus. If she was plus, he is minus, they wouldn't care. Because now they can welcome both, plus or minus. That's welcome when the mom is Rh positive. The problem is when the mom is Rh negative, she will only welcome negative, but if there is positive, they will send antibodies that will destroy that red blood cell. Yes?
Doesn't something similar happen if your immune system detects your eyes? I heard that, like, if it detects your eyes, it can attack the healthy cells.
It's not just your eyes, it's your eyes, your liver, for liver transplant, that's known as graft rejection, for kidney transplant. But the concept is the same, that your immune system recognizes through immune surveillance that there is a foreigner glycocalyx. This foreigner glycocalyx is understood by the immune system as an invader, as dangerous, something needs to be destroyed. But that's not the case. These are red blood cells. So we give the mom an injection called as anti-D injection. This anti-D injection was given to the mom. That anti-D injection is gonna make the mom Rh minus or Rh positive. It's gonna make the mom Rh positive. So now if the baby is Rh negative or Rh positive, no problem. So when the mom immune system, while she was Rh negative and the baby is Rh positive, and that leads to the destruction of the baby's red blood cells on the first pregnancy or the second pregnancy? Second pregnancy. What is that called? Erythroblastosis fetalis. Yeah, hemolytic disease of the newborn. Very good. Hemolytic disease of the newborn, or yeah, because you remember when we talked about the destruction and the recycling of the red blood cell. You see? Bilirubin, excellent. Yeah, very good. So that's what we did. Where's the slide? Right here. So we need to recycle our we have hemoglobin. Globin is taken back to make, globin is protein. We recycle it, we get proteins back. Is the heme that would be converted into iron that would be used for iron homeostasis, and the heme is going to be broken down into bilirubin. But the problem is when you have so much heme broken down, there's going to be transport maximum. They're gonna saturate. You have too much now. Then that's gonna be released in the body. That is known as, like you said, jaundice. So that's another example. It's when your immune system recognizes that there is a foreigner glycocalyx. All of the red blood cells that have foreigner glycocalyx recognized by your immune system as enemies, they will get cross-linked in a process known as agglutination. Agglutination. Agglutination is the process of cross-linking all of the enemies, or at least the perceived enemy, the supposed enemy, your baby's red blood cells, or even let's say I donate red blood cell to a patient who's of a different blood type. My red blood cells are going to be recognized as different glycocalyx, and they are going to get agglutinated, cross-linked, rounded all up together, bundled up. Agglutination is when you cross-link the immuno antibodies. When you cross-link the antibodies, is when you cross-link the antibodies of different, that's red blood cell 1, red blood cell 2. When you cross-link all of them and you bundle them, you round them up. You stick them like glue, like glue. That's why they call it agglutination. Agglutination. Okay. So, if you are blood type A, you get blood. If you are blood type A, you get blood type A, no agglutination will happen. But when you see there is agglutination here, that means this is blood type A. It was not given A, it was given B. That's why they agglutinate together. Agglutination. Anti-B is when you are blood type B, they give you, so if you are blood type A, you are anti-B because you're A, you're anti-B. If you're B, you're anti-A. So if you have if you have A blood type, they mix with it B, and you see agglutination, you know that you were given B. If you have blood type B, they mix some blood with you, no agglutination, that's B like you. If you're blood type B, they put another blood in there that causes agglutination, you know that's different. No agglutination except that your glycocalyx is different. So that's the glycocalyx on the surface. So blood type A looks like that. I like to draw it with A's on the top just to show that these are A glycocalyx. Blood type B, they look like that. A, B, they have both. This is very important. And O, they have no different. That's why they are the universal donors. Everybody does not, you can go, nobody damage them. That's like a little baby is going into the little children going inside the women bathroom or little children going inside the male bathroom. They're not going to be targeted. But if a male goes into the female bathroom, or if the female goes into the male bathroom, then that is a problem. So the A has the A type. Maybe for that's a particular blood type, and B has a particular blood type. And then you have the somebody who can enter both bathrooms. You know that happens now. There's male bathroom, there's female bathroom, and you can enter both. And there is somebody who is so harmless, he can enter both. You want to change a diaper. So, so if you are blood type A and they give you to somebody who is B, so now you see the blood type B, blood type B, you already have anti-A. You see, they have something that look like a circle because they are a diamond. And B, they have something that looks like a diamond because they are a circle. So type A has anti-B, and type B has anti-A. So that means type A, you need to know the difference between an antibody and an antigen. An antibody is what you use to destroy and kill. An antigen is who you are. An antigen is your glycocalyx. An antigen, like genetics, that's who you are. Antigen, that's who you are. The mom's blood, the mom immune system does not destroy the red blood cell of itself because they have the same antigen. But the mom immune system will destroy the baby red blood cell because they have different antigens. Thank you. Where do we find the antigens? On the glycocalyx. Thank you. So the glycocalyx is antigen. That's antigen. That's who you are. So the anti-B will target the B antigen. You see? So blood type A has anti-B antigen to recognize B antigen because we don't want B antigen. So in the male bathroom, you have a security guard detecting if female is gonna come in there. On female bathroom, you have female guards to make sure no male. No. In male bathroom, you have female guards to make sure no female will come in. Let's make it an example like that. So in female bathrooms, you have male guard to prevent male from coming in. So that's what we see here. A blood type has anti-B, anti-Bs to target B antigen. On the B blood type, you have anti-A to target A antigen. So on the female bathroom, outside you have male guard to prevent male from coming into the female bathroom. On the female bathroom, you have female security guard. On the male bathroom, you have female security guard to prevent female from coming in. That's a good analogy, actually. It's a very good, it doesn't happen, but that's a very good analogy. Imaginary analogy. And on AB, you have no at all antibodies because both they can enter. The male and the female, they can enter the same bathroom. I wouldn't have been able to give this example 20 years ago. But this is an efficient example now. So now A and B antigens are both found on the red blood cell because that bathroom can allow both to go in. So you have female antigen and you have A antigen and B antigen. So everybody can go in. So This is why they call the AB a universal recipient. You give them blood type A, they welcome it. They have no, you see, they have no antibodies. They have no anti-nothing. They have no anti-A or anti-B. So they welcome everybody. These are the universal recipients. And O is the, why is O the universal donor? Because the universal donor, you see, it has at all no type of glycocalyx. So it can fit in anywhere. It cannot ever be detected by anti-B or anti-A. So they are universal donors because they cannot be targeted. They don't have think of it as they don't have glycocalyx. They can just carry the oxygen in the blood and move through. They will never be destroyed or damaged. It's very, yeah. Yeah.
Let's say like a person so this would be O negative, right? The universal donor.
No, negative and positive is for RH.
Okay, so what?
So just O. So this convention is letters. When you hear positive and negative, we're talking about the mom, the erythroblastosis fetalis.
No, I'm just saying, so if you have like someone with like type of O and then they have an organ plant, because there's no blood power expression, how would the body determine what's foreign, with the case for rejection?
Okay, so I'm not sure I got the question. Can you say it again, please?
Yeah, if somebody with blood type O gets an organ transplant, you said O doesn't have a glycocalyx, right? So how would rejection occur from rejection of the organ and stuff?
Okay, so what is this rejection of? What are we rejecting here?
We don't, in O, we don't, it's a universal donor because it doesn't have like glycocalyx, it doesn't, it doesn't look like.
Get recognized.
Right, it doesn't get recognized. Oh, okay, I think I understand now. So if it doesn't get recognized, that still doesn't mean that it doesn't have antibodies, it still has anti-A and B.
It doesn't, it has, okay, it has no glycocalyx. It does not have anti-anything. Because if it does not have any anti, because you see, so in the plasma, you always have antis of those opposite to you.
Yeah.
So they are O type. The example you gave about the liver, that's an organ transplant.
Yeah.
Here we're talking about blood transfusion.
Okay.
So that is there's a whole system for rejecting or accepting organs.
Okay.
So a blood type O is not going to damage any red blood cells. But for the tissue, that's a whole different system.
Really? Okay, I thought because, the blood is everywhere in the body, so that's why.
Yeah.
So that doesn't cause any like health conditions, having like type O blood?
No, that's just an advantage because it's actually an advantage to other people. So you can help other people. But it's not an advantage. The advantage one is the AB guy. That gets it from anybody. Okay, you're A, you're B, because he does not have, he does not have, you see, you always have weapons against your opposite. If you're A, you have anti-B. If you're B, you have anti-A. Remember the example I gave you? You don't want man in the female bathroom. So you have a man guard to prevent men from going into the female bathroom. So the same thing here. If this is A glycocalyx, you need anti-B to detect B antigens. So always you need to have antibodies against your opposite. You don't want to destroy your own self. The O guy has no antigens. So he will not have anti-A and he will not have anti-B. So when he cannot be detected, so when his blood is flowing inside the transfusion to the other party who is being donated to, it will not be destroyed. It will be used significantly.
But if it's a universal donor, would it also be a universal recipient, or does it only take?
Impossible to be okay. Think about this. Being a universal recipient means what? Means you will not destroy anybody. That means you don't have anti-A and anti-Bs. That means you have to have both. Remember? That's when we said the bathroom where you can enter both genders. So here, there's no guard to prevent this from here. It's open. So that's the same thing here. So they have both. You see, that's antigen A does not welcome B. That's antigen B does not welcome A. This has both A and B. So it cannot target anybody. So if you give them blood type AB, they will take it. You give them blood type A, they have no anti-A, they will take it. You give them blood type B, they have no anti-B, they will take it. These are the lucky ones, ABs. But blood type O is a universal donor. So when you give the blood type O to other people, their immune system is never going to destroy it because it has no B's or A's. It has no B's, it has no B and it has no A antigen, no B antigen, and no AB. So it will never get destroyed. But him, he has anti-A, anti-B, and anti-A because he doesn't have those antigens. So he is the destroyer of everybody except himself. So he gotta get O. He's a universal donor, but he's a very picky. So that's why these are the least lucky because they give others, but they cannot get except O. It has to be O. Okay? Okay, done with blood. Now we're gonna go into the heart. We talked a lot about this in the lab. So the heart is a pump. We said we are so preoccupied with gradient. There's no movement without gradient. Why you come to the school? The gradient is the driving force. You know, you're coming here because you need to get a degree so you can get a job so you can make money. If there was no degree, there was no job, there was no money. Are you waking up to come here at 9 a.m.?
No.
No. So there's got to be a driving force. We learned in biology that's a psychological gradient.
An
That's
incentive.
an intensive, yeah, an incentive. Intensive incentive. I made that up. It's an intensive incentive. But I actually attended a 6-hour lecture before it was an intensive. It was brutal. But anyways, so we have to have gradients to move. If we want to move electrolytes, we need to have an electric gradient. If we need to move glucose, we need concentration gradient. If we need to move heat, we need thermal gradient. If we need to move fluids, we need pressure gradient. We need pressure gradient. So if I'm gonna push my blood, we talked about this in the lab. You have to divide, like I said, there's no way, if you stick to one way of understanding, you will get the topic. You can never stick to anatomy and now physiology, and you can never stick to physiology and no anatomy. If you guys take really long breaks and you're missing a lot, and all of that is going to be on the exam. So please make sure that you're very moderate with your break because you're going to miss a lot of information that's going to be on the exam. And then you got to go back and listen to all of that.
Okay.
So we need a gradient to push this blood. Something has to push you. You woke up because something pushed you. You were pushed. I need to be here. Why do the red blood cells need to be pushed? Because of the ventricles. So the ventricles push. Why are the ventricles pushing? Because the nervous system sends electricity, depolarization. So the depolarization makes contraction, contraction makes pressure, pressure makes blood flow. So you're gonna keep, I'm telling you, the best way to study is to go back and forth. Anatomy, physiology, until you get it. But you cannot stick to just anatomy or you cannot separate them. You have to look at them, you have to oscillate, toggle back and forth. So if we look at if we look at if you look at the circulation, you have your this is the human heart. We have looked at that in lab. What is this? That's three tubes coming out. So on the written exam, if I bring you a photo like that and label this number right here, that's the aorta right here before they branch out, the aorta. But this curve here, this arch, what is it called? Excellent. This aortic arch has three branches coming out of it. So the three branches coming out of it, what is the one that is most medial? This one. No, the ascending aorta is this one. This is the descending aorta. This is your brachiocephalic. No way you say this is the vena cava. Impossible. This is the aorta carrying good blood. Why would the vena cava have anything to do with the aorta? So remember, it's not just an issue of anatomy. It's also an issue of physiology. So if you know that the aorta carry red blood cells that are rich in oxygen, red blood, there's no reason for you to say vena cava because they carry blue blood. So you see now how physiology helps you understand the anatomy. So even if this was a lab practical, you had to identify structures. You don't know anything about this structure by process of elimination. You know 100% there's no way that this red branch could be vena cava. Vena cava has to be blue because it carries the deoxygenated blood. This is the brachiocephalic trunk. This is the left carotid. This is the left common carotid. And this is the everything left because we're going left, right? That's my heart. That's my heart curving left. So you have your ascending aorta, you have your aortic arch, and then you have you have your brachiocephalic trunk. The first one left is your brachiocephalic trunk. The one in the middle is the left common carotid. And the one next to it, still the left subclavian. Subclavian artery or vein? Artery, because we're dealing with aorta. Excellent. Very good. Very, very, very good. The position of the heart is found in the thorax in the mediastinum. The heart is located within the thoracic cavity, not the abdominal cavity. So a simple question would be, where do we find the heart? The thoracic cavity, the abdominal cavity, the pelvic cavity. Where do we find it? Somebody puts the pelvic cavity, the heart in the pelvic cavity. Between the lungs and the mediastinum. In the mediastinum, it is about the size of one's foot. It is broad at the top, called the base, and it tapers towards the apex. Okay, if the heart should stop, CPR can maintain the flow of blood until the heart resumes beating. So by applying pressure to the sternum, the blood within the heart will be squeezed out of the heart and into the circulation. So proper positioning of the hand on the sternum to perform the CPR would be between the lines T4 to T9. Okay, so this shows us our blue blood and our red blood. Red blood at all times, that is oxygenated, oxygen-rich blood. Blue blood is deoxygenated blood. So there we go. This is the left side. We said left is the left of the body, the left of the cadaver, the left of the anatomical position. So that's the left heart, left pump. It has atria and ventricle. The right has atria and ventricle. And these are the vena cavas. You see, that's the superior vena cava. What's the difference between the superior and the inferior vena cava? Yeah, one brings in oxygen, one takes it out. Wrong. Yes, that's true. One is above, one is below. But what is the difference?
The period is longer, because like the end period is much shorter.
Actually, the opposite. The inferior brings blood from the inferior part of your body, your legs, your thighs, your abdomen. So they are really long.
Like all the stuff
From
on
the
upper
upper
body.
body.
Yeah. So the
Like from your
superior.
lungs, from
Yeah.
your like brain and all that stuff, like from up here to down here.
Yeah, so that's a lot shorter. So that is your superior vena cava is bringing in draining. Just what I say, draining. We are draining bad blood from the superficial and deep layers. Superficial and deep layers. Okay, so the blood in the pulmonary artery branches is low in oxygen, but relatively high in carbon dioxide. The gas exchange occurs in the pulmonary arteries. So you have oxygen in the blood, and carbon dioxide is going to be removed out. And the blood is high in oxygen and low in carbon dioxide, is returned to the left atrium. So this is the cycle. You have to know this cycle. There is no way around it. You must understand that wherever you, it's a cycle. You can begin from the tissue. You can begin from the pulmonary circulation. You can begin anywhere, but you must be able to trace the blood. So let's begin from here. So what does this represent? That represents a venous side of the capillaries that is taking and draining bad blood from the skeletal muscle and from the tissues of the body, returning the bad blood through the vena cava. That could be, even though it's only down, it could mean both. Superior and inferior vena cava, because in the end of the day, we are this is the inferior vena cava, that's the superior vena cava. You see, this is up here is my tissue. You see my meshwork? That's my network. That's my tissue. So you have bad blood coming from the head and neck down through your superior vena cava. You see the superior vena cava. On the bottom, you have bad blood returning from the systemic circulation through the inferior vena cava. Both of them converge and they meet together inside your right atrium. The right atrium would squeeze and all the bad blood, the right atrium would squeeze and all the deoxygenated blood is going to flow through the what kind of valve? You have to pay attention. What kind of valve here? Valve. Excellent. Tricuspid valve. Tricuspid valve is going to allow bad blood returning from the inferior vena cava and superior vena cava into the right ventricle. The right ventricle is going to pump out this deoxygenated blood here. What's the name of this valve here?
The pulmonary.
That's semilunar valve and it is pulmonary. So now we exit it. Where do we go now? You see these two lobes here? That's my lung. That's my lung. So we go to the left lung and right lung as blue and we return as red. We have been now nourished with oxygen and carbon dioxide has been removed. Then we return as red into, you see these two holes here? Left pulmonary veins. You see these veins here bring in the blood into my left atrium. The left atria now, when depolarized, will contract and enter from the left atria into the left ventricle. Then you squeeze, the left ventricle is going to pump out all the oxygen, oxygenated blood from the left ventricle into the aorta. Aorta. And then the aorta is going to go, this arch here. What's the name of this arch? Aortic arch. What's the name of the first outlet from the aortic arch? That's your brachiocephalic trunk. Excellent. What's the name of the middle? The left common carotid. Excellent. What's the name of this one? Left subclavian. Excellent. Okay. Pericardial membranes and layers of the heart wall. So we talked about this on the lab. We said we need to encapsulate and cover our heart in fibrous tissue, in fibrous tissue that is gonna be protecting us from trauma. Why do we have this capsule? So because the heart is beating against, especially your ribs. So it's hitting the ribs. What's the name of that beat? The beat when your heart, huh? What is it called? Apex beat. Yes. Why are you sorry? Yeah, I didn't hear it. Okay, I have a hearing deficit. So you got to be a little louder. It doesn't mean you're wrong. So you have apex beat. Now imagine this apex beat is going on all your life, and there's no capsule. You're hitting the rib cage, and there's no fibrous capsule around you. What's gonna happen to the heart? It's gonna fissure up, ulcer up, injury. It's gonna bleed. So how many fibrous capsules you have? You have the outer one known as the fibrous pericardium. Then you have two double epicardiums, and there is liquid inside them, serous liquid. These are known as the one that is touching. This is your heart, right? There's a red. The one that is intimate, touching your heart. Is that the visceral or the parietal epicardium? That's the visceral. That is your visceral epicardium. And this layer here, the epicardium, is also known as the visceral pericardium. And the one that is not touching the heart, but is rather touching the liquid, is known as the parietal layer of the pericardium. And this is the fluid. So you have three layers: fibrous pericardium, parietal pericardium, and you have serous fluid, then visceral. Then you have visceral pericardium known as the epicardium. So only this very inner layer intimate with the heart tissue, that is known as the epicardium. But all of them are known as the pericardium. Fibrous pericardium, parietal pericardium, serous fluid, visceral pericardium, or epicardium. That's, you have how many capsules? 1, 2, 3, 4 to protect the heart. There we go. That's all the brachiocephalic trunk. You see the brachiocephalic trunk? The middle is the left common carotid. And the last one is the left subclavian. Who brings back good blood back into the atria so it could get thrown down through the bicuspid valve into the ventricle? These are the pulmonary veins. Very good. So these are the muscles that surround the heart. And, when the heart is relaxed, that is known as diastole. Diastole, when the heart relaxes. When the heart contracts, that is known as systole. Systole. So when we take a blood pressure measurement, and we say, oh, your blood pressure is too high, you have hypertension. Oh, your blood pressure is too low, you have hypotension. What does that really mean? So when we take a blood pressure measurement, we have I'm sorry? I cannot hear. That was another hearing deficit. What is it? What is it you guys saying? Systolic. Systolic over diastolic, which is the same thing as contraction, because contraction causes systole and diastole causes relaxation.
So is it the muscles that make relaxation or just the heart?
Muscles.
the heart muscle. So the two atria contract at the same time, and then the valves open, make the sound lub, lub. Then they shut after when they shut down, when all the blood goes through from the left atria, from the atria into the ventricles, then the atrioventricular valve shut. That's known as lub sound. Then from the ventricle into the semilunar valve, and then after the semilunar valve shut down, that's no longer lub, that's known as dub. So normally you hear two hard sounds. Lub means tricuspid valve shut down. Dub means semilunar valve shut down. Somebody with a heart murmur, they can have their blood leaking through those valves. There's a reflux. So this is no longer lub dub, two sounds. They have three sounds. They don't have lub dub, lub dub. They have three sounds. Lub dub drub, lub dub drub, lub dub drub. So that is very dangerous. Okay. All right. So we have systolic over diastolic. Contraction, relaxation. The same thing as depolarization, because depolarization, we depolarize, then we repolarize. So in systolic blood pressure, we contract and we depolarize. In diastolic, we relax and then we repolarize. So the most perfect for us, the most perfect blood pressure for us is 120 over 80. Above that, this is U tension, 120 over 80. Hypertension is when you have more. So more than 125 over 80, that's going to be hypertension. Hypotension is when you drop between 120 from 120 to below the 80. That's dangerous. That's hypotension. So we've seen those. What are these? We said in lab, these are parachute-like structures. What is the name of these parachute-like structures called? Chordotendinae. These are the chordotendinae. These parachute-like structures, they are hooked on one side to the valve to prevent the valve from refluxing. And on the other side, they are hooked to what kind of muscles? Papillary muscles. So in your heart, you have the valve. So this is your heart, and that's the septum, and you have your valve, bicuspid valve, and you have your parachute-like structures. The parachute-like structures are your chordotendinae, and there are muscles here, PPP. These are your papillary muscles. These are the papillary muscles. These papillary muscles hold like a parachute this bicuspid valve from refluxing when the ventricles contract. Otherwise, when the ventricles contract, we only want to open the tricuspid valve of the aorta so the blood can go out, flow out from the ventricles into the aorta and go out to the body. But if there was no chordotendinae, both will open. So now you have blood flowing into the aorta and back into the left atrium. Okay. So you see my bicuspid valve. So you see everything is tricuspid. Everything is tricuspid except this valve is bicuspid. And this is your tricuspid valve. So that's the valve between the aorta and that's the valve between the right atria and the right ventricle, and that's the valve between the left atria and the left ventricle. And you have also the aortic valve. It is between you see the semilunar valve are always between the ventricle and the blood vessels. While the atrioventricular valve, from the name, atrioventricular valve, they are between the atrial and the ventricle. And the only one who is bicuspid is the
The left
the left
side of the heart.
the left ventricle,
The left.
the left atrioventricular valve. You see, some people may have bicuspid aortic valve. That happens. Bicuspid aortic valve. Some people can have a bicuspid pulmonary valve. That happens. Some people can have a bicuspid tricuspid valve. It can happen.
But you wouldn't get points off that though, if you just say left ventricle, or you have to say left aortic.
What do you mean? I don't understand.
Like, you see how you said the bicuspid, and you said, you asked like, what was the other, name for it? Would you?
Mitral valve, you mean?
Yeah, would you get points off if you just say like, being at on the left side, would you get points off if you say?
Well, you have to specify it is a left atrioventricular valve. Then that'll do it because there's only one left atrioventricular valve. But if you say bicuspid valve, that's 100%.
About that, oh,
But if you just say tricuspid valve, that's half a point because there's two of them, you see? I'm sorry, if you say atrioventricular valve, there's two of them. The bicuspid valve is atrioventricular between the atria and the ventricle. And so is the tricuspid valve is atrioventricular on the right side.
So if we just say bicuspid valve.
That's definitely because there's only one bicuspid now. You you specified it now.
And then we just say pulmonary valve, that's 100%, that's aortic valve, that's 100%.
Yeah.
Okay.
Exactly. Okay. So we mentioned how the action potential travels through the gap junctions. These leakage points, you see the gap junctions allow for solutes to pass through. They allow for solutes to pass through the cells. And that's gonna, they allow for solutes to pass through the cells. And that's gonna make the actual contraction, the depolarization, and the depolarization going to cause the sarcomere to get longer or shorter. If the muscle is going to contract, will that make the sarcomere longer or shorter? Going to make it shorter. In order for, you remember we said we put systolic over diastolic, and systolic means we pump, we contract the heart. We also have to appreciate that we relax the heart with diastole. We relax the heart with diastole. So in order to relax the heart, we need repolarization. You see, repolarization. Depolarization is the contraction of the heart. So there are specialized conducting components of the heart. The first one, they are always on the right side of the heart. You have your sinoatrial node. That's very important. The sinoatrial node, these are the ones responsible for the depolarization. So they depolarize the atria. You see these dotted lines? That means these are action potentials that are going from the sinoatrial node into the right atria and the left atria. Then you have action potentials flowing down the ventricle, and that after the sinoatrial nodes fire, you have your atrioventricular nodes, and then they will continue firing and they will cause the depolarization of the ventricles, which means the contraction of the ventricles. So now you know you can never have both of them contracting at the same time. And you can never have both of them relaxing at the same time. So if the atria are depolarized and contract, the ventricles have to be repolarized and relaxed. And then we oscillate, we change the cycle. If the atria are relaxed and repolarized, That means the ventricles are now depolarized and contract. So the sinoatrial node and the remainder of the conduction system are first at rest. You see, they are at rest. The sinoatrial node initiates the action potential, which sweeps across the atria, So after reaching the atrioventricular node, there is a delay of approximately 100 milliseconds that allows the atria to complete pumping the blood before the impulse is transmitted to the atrioventricular bundle. Then following this delay, the impulse would travel through the atrioventricular bundle and the bundle branches to the Purkinje fibers. And they also would reach the right papillary muscle via the moderator band. The impulse would spread to the contractile fibers of the ventricle, and the ventricular contraction is going to begin. So, the action potential at the sinoatrial node. So the pre-potential, you see, remember when we talked about the depolarization, is due to the slow influx. There is slow influx of sodium. That's the pre-potential. Slow influx of sodium ions until a threshold is reached, followed by a rapid repolarization, a rapid depolarization, and repolarization. And this repolarization and depolarization are both caused by what? The outflux of potassium. So the prepotential accounts for the membrane reaching the threshold and initiates the spontaneous depolarization and contraction of the cell. And then we begin again with the slow influx until we hit our threshold, and that's going to cause our depolarization. So the action potential in the cardiac cells begins with a long plateau phase. Okay, this long plateau phase is due to the influx of the calcium ions. So the extended refractory period allows the cell to fully contract before another electrical event can occur. So the action potential for the heart muscle is compared to that of the skeletal muscle. So the standard placement of the ECG leads. So in a 12-lead ECG, there are 6 electrodes that are placed on the chest and 4 electrodes that are placed on the limbs. So the P waves represent for me the depolarization of the atria. And then you have your QRS complex. So at a normal tracing shows the P waves. This is your QRS complex, and that is the T wave. These are also indicated in the PR segment, which includes the P waves, the Q up until the R region, and then the QT segment, then the QRS, then the ST intervals. So if we examine now, we try to match between the waves and the actions of the heart. You have the P waves, the QRS, and the T. At the beginning, when you are at rest, you have just ended your cycle. So now you are repolarizing. Then the influx of sodium is going to cause this P wave. The P wave initiate that we're going to depolarize the atria. So now we are squeezing, contracting the atria. When we are squeezing and contracting the atria, the blood is going to flow from the atria into the ventricle. So you have the QRS complex initiating that we have depolarized the atria, and now the action potential is spreading down the the interventricular septum, the Purkinje fibers, and the bundles of the His and the bundle branches. And now we have reached the apex of our heart, and we are ready now to depolarize the ventricles. The ventricles will now depolarize, and after that, in your T wave will represent a relaxation of the ventricles. So here you have depolarization of the atria and repolarization of the ventricles. Depolarization, contraction of the atria, repolarization, relaxation of the ventricles. Here, depolarization of the ventricles and contraction of the ventricles and repolarization of the atria. So that just shows us a form of arrhythmia. Arrhythmia is when there is a disturbance or a disruption in the rhythm of the electric conduction of the heart. So let's look now at second degree partial block. In the second degree partial block, one half of the P waves are not followed by the QRS complex, and the T waves while the other halves are. So you see, you're supposed to have a P wave, QRS, and a T. But here you see a P wave that has no QRS. So that's arrhythmia. You're supposed to look like that. PQRST, PQRST, PQRST. But here you have PQRST and another P, then another P. That's wrong. You're not supposed to have that. So that's an example of arrhythmia. That's a second degree partial block. Now let's look at atrial fibrillation. In atrial fibrillation, the electrical pattern is abnormal prior to the QRS complex, and the frequency between the QRS complex has increased. So let's look at atrial fibrillation. You have a lot of QRS complexes, but no P wave. You see a lot. You see there is increased frequency. So much P waves between the QRS complex. So much P waves between the QRS complexes. So that does not look like this. That does not look like PQRST. That looks like PPQRS, PPQRS, PPQRS. It was supposed to be PQRS, PQRS. Here you have so many P's, then a QRS and no T. PPPP QRS no T, PPPP QRS no T, PPP no QRS, no QRS, and then so that looks like arrhythmia. That is not normal action. That is not normal rhythm of the heart. Let's look at ventricular tachycardia. In the ventricular tachycardia, the shape of the QRS complex is abnormal. So now you don't see QRS, you see V shape, V shape, no QRS, no QRS. So that's ventricular tachycardia. Now look at ventricular fibrillation. In ventricular fibrillation, there is no QRS at all. There is just abnormal electrical activity that looks like just waves, not even P wave, just disordered abnormal waves. In a third degree block, there is no correlation between atrial activity. There is no P wave and no QRS. So QRS represent the ventricle and the P represent the atria. Here you see neither. So that's a third degree block. You don't see a P wave or a Q wave. But all that you see here is that this is an example of the arrhythmia. That's an example of arrhythmia. So a defibrillator is very important because it is an external automatic defibrillator, and it could be used by non-medical personnel to reestablish a normal sinus rhythm. The defibrillator paddles are more commonly used in hospital settings. Okay. Hmm? Yeah, these are old defibrillators, but they do the job. They get the job. Especially if you have a patient at home, like your elderly, your parents, your grandparents, you gotta have your defibrillator because one day If they had a heart attack, if you had a defibrillator, you may save their lives. When grandmother had the heart attack, we had no defibrillator in the house, so she died.
They just sell those to anyone?
Of course.
Like at home, like,
Yeah, yeah. Yeah. You could use them if you have like you take a first aid. They're not that complicated, but they are very important in resuscitating.
Like, you gotta get that over the counter or?
Not over the counter. You request it, and this is like a CPR course. It's like how you press on the
Yeah.
they
compress.
use it a lot, when they do like organ transplant.
Yeah.
No, I'm just saying because I could probably,
Okay. So that's because of what?
no, I'm just saying like, just in case.
Yeah. So always just in case. Always just in case. Always prepare for the just in case. So have your defibrillators, have your first aid, have your first aid packs. Today my car the battery died. I should have had an extra one, did not. So always have your just in case. It's actually not a just in case, it's the just always. The cardiac cycle begins with atrial systole. We compress the atria, and then there's atrial diastole. We relax the atria. And that is represented by the P wave. So P wave, we're dealing with the atria. QRS, we're dealing with the ventricles. So atrial diastole and ventricular diastole, when the cycle begins again, they correlate to the ECG that are highlighted. So here you see atrial contraction, you would have atrial systole beginning. And in isovolumic or isovolumetric contraction, that is the phase right before you contract. That's why they call it isovolumetric, because you haven't yet contracted. You just began. You're just about to contract. But when you have your ventricular ejection, that is when you successfully contract. There is isovolumic and isovolumetric relaxation. There is a ventricular diastole. Ventricular diastole, that is so in isovolumic or isovolumetric relaxation. In isovolumic or isovolumetric relaxation, you would have the phase that is right before you relax. So if I ask you what's the difference between isovolumetric contraction, and just normal contraction, and isovolumetric relaxation, and just relaxation, what's the difference? So in isovolumetric, you are about to begin. So in isovolumetric contraction, you're about to begin contracting. And isovolumetric contraction, relaxation, you're just about to relax. You're just about to relax. So that's the P wave initiating. Atrial diastole has just ended. Then we're beginning the atrial diastole. So atrial diastole ends. That's why they call it the PR interval. That includes the Q from P all the way to R. It includes atrial diastole and atrial systole. Then, right beneath it, because remember we said both of them. If you're doing systole, if the atria are doing systole, the ventricles are doing diastole. If the atria are doing systole, the ventricles are doing diastole. And if the atria are doing diastole, the ventricles are doing, they are opposite. If the atria are doing systole, the ventricles are doing diastole. And if atria are doing diastole, the ventricles are doing systole. Okay. So the PR interval outlines my atrial diastole and my atrial systole. And your atrial diastole represents your R to the end of the T wave. So the atria would begin to relax from the end of the PR interval up until the end of the T wave, while the ventricles would have their diastole from the end of the T wave up until the PR complex, up until the end of the PR complex. But from the end of the PR segment to the end of the T segment, that is your ventricular systole and ventricular diastole. So diastole begins at the end of the T wave. Ventricular diastole begins at the end of the T wave and ends at the end of the PR interval. So ventricular diastole begins at the end of the T wave and it continues up until the end of the PR segment. That is ventricular diastole. Ventricular systole begins at the end of the PR segment up until the end of the T segment. Heart sounds on the cardiac cycle. We talked about the heart sounds. We said that when both the atrioventricular valves closed, the mitral valve shut down, and the bicuspid valve shut down. Is that lub or dub? You see? That's lub. Dub is when you have the shutdown and the breaking of the closure of the semilunar, the breaking of the semilunar valves. The stethoscope placement for an auscultation. So the proper placement of the bell of the stethoscope facilitates auscultation at each of the 4 locations on the chest. So that is your mitral valve or your bicuspid valve. That is your tricuspid valve, and these are your pulmonary valves. This is the pulmonary valve, and that is the aortic valve. The aortic valve is sending blood to the left of the heart, and the pulmonary valve sending blood back out to the lung, and tricuspid valve bringing blood into the right ventricle, and this mitral valve bringing blood from the left atria into the left ventricle. So the heart rate is known as how frequent does your heart contract. So the cardiac output is equal to the heart rate times the stroke volume. So the cardiac output is influenced by heart rate and stroke volume, both of which are also variable. There is a cardio accelerator and cardio inhibitory areas. These are components of the paired cardiac centers located in the medulla oblongata of the brain. You see, that is the medulla oblongata. That is where your cardio acceleratory center is placed. They innervate the heart via sympathetic cardiac nerves that increase the cardiac activity and the vagus parasympathetic nerves that slow the cardiac activity. So the parasympathetic and sympathetic stimulation on the heart. The sympathetic stimulation would cause an increase in heart rate. So the wave of depolarization in the normal sinus rhythm shows a stable resting heart rate. You see that stable resting heart rate. But for parasympathetic, you see the frequency is less. So you have less, you would have a slower depolarization, and you would have a separation. You would have a prepotential spontaneous depolarization. So you have less, you'd have less complex here. But this shows you the heart rate has increased. So if you look, examine, compare those two. Where is the heart rate the highest? Here, on the top, or on the bottom? The heart rate, what is it increasing a lot? On the bottom or in the middle? Here. Is increasing in the bottom. There's like 3, 4, 5 peaks. And here there's only 2. So that is known as decreased heart rate, and that is known as increased heart rate. Major factors influencing the stroke volume. There are multiple factors that impact the preload, the afterload, and the contractility. And these are major considerations for stroke volume. So the preload is the amount of blood that um, preload is the amount of blood that has to be channeled inside, the amount of blood that has to be put in the ventricles before the cycle of contraction begins. The preload, the contractility is how often your heart contracts, and the afterload is the resistance that stands in the face of the blood as the blood is leaving the aorta. And diastolic volume is how much blood stays in the ventricles right after the diastole phase has ended. So we relax the heart, we accommodate the heart with a lot of blood, and that is the end diastolic volume. The end systolic from the name, end diastolic and end systolic. End diastolic volume is when we relax the heart and we fill it with blood. How much blood are we filling the heart with? That is end diastolic volume. When we compress, how much blood is ejected from the ventricle? That is known as end systolic volume. Okay. Okay, so when we talk about the blood vessels, now we need to understand the dynamics of how does the blood flow inside our body. We need conduits. We need these tubes, these passageways in which blood is going to pass. So blood vessels, while most blood vessels are located deep from the surface and are not visible, the superficial veins of the upper limb provide an indication that that's how they began to study the anatomy, because they see these tubes and they're like, what is that? What is flowing inside them? So we have learned that the pulmonary circuit is a circuit that involves the lung. That's why they call it the pulmonary circuit. And the pulmonary circuit moves the blood from the right side of the heart to the lungs and back to the heart, while the systemic circuit moves the blood from the left side of the heart to the head and the body, and it returns it to the right side of the heart in order to repeat this cycle. So the arrows indicate the direction of the blood flow, and the colors show the relative levels of oxygen. So red means we are oxygenated. Blue, we are deoxygenated. If the blood vessels have anything to do with the lungs, what do we call that circulation? If the blood vessels have anything to do with the lungs, what do we call that circulation? Pulmonary circulation. And if the blood vessels have anything to do with the tissue down here, what do we call that? Systemic circulation. So blood is going to flow out of the pulmonary artery and it's going to go into the lung. It's going to get perfused, and the oxygen is going to flow away from the lung and is going to enter into the left side of the heart. The heart is going to contract and the blood is going to leave the left ventricle and is going to perfuse the tissue. So the pulmonary circuit moves the blood, so it's going to perfuse the tissue, and then all the metabolic waste and the carbon dioxide are going to be removed from the tissue and returned back into the right heart. Okay. Structure of the blood vessels. Arteries and veins share the same general features, but the walls of the arteries are much thicker because of the higher pressure. Because you know the blood, the heart pumps through your left ventricle, and all of the pressure is going to generate and accumulate in the aorta. A micrograph shows the relative differences in the thicknesses. So you see what is more thick, the vein or the artery? What is more, the artery is more thick. Why is the artery more thick than the vein? Why is the artery more thick than the vein?
The higher pressure of the blood that goes.
Yeah, because that accommodates a severe amount of pressure that strikes the wall of the blood vessels. Okay. What are the types of the arteries and the arterioles? So we have elastic arteries, and you know that the blood vessels have three layers. There's the tunica externa, the tunica media, and the tunica intima. So the tunica intima is the layer that is intimate with the blood. That is the tunica intima. Then you have the tunica media. This tunica media is the middle thick layer that is rich in smooth muscle. And then you have a fibrous capsule that is your tunica externa all the way on the outside. So we have different type of capillaries. Some capillaries are continuous, so they have a basement membrane and they have an endothelial layer. That's their endothelial layer, and they have gaps. These gaps, who gets out of these gaps? Who gets out of these gaps through these gaps? The macrophages. They go to the tissue if there's an infection through these clefts. Remember I said endothelial cleft, endothelial gap. Through these gaps, your macrophages are able to get out. There are fenestrated. There are fenestrations, and these fenestrations are holes in addition to the interendothelial gaps through which the red blood cells are going to come out. Sinusoids. The sinusoids have an incomplete basement membrane. We talked about those as the sinus histocytes. These sinusoids, they are able to leak out. They are able to leak out the blood, and we see them a lot in the spleen. So the spleen has a lot of sinus histocytes, and these sinus histocytes are where we target the red blood cells because the spleen is the graveyard of red blood cells. In a capillary bed, so in a capillary bed, arterioles give rise to meta-arterioles. And there are precapillary sphincters located at the junction of a meta-arteriole with a capillary that regulates the blood flow. So a thoroughfare channel connects the meta-arteriole to a venule, and arteriovenous anastomosis. This is your arteriovenous anastomosis that directly connect the arteriole with the venule. This is your tunica externa, that's your tunica media, and that is your tunica intima. We have valves in our veins, and that's very important for deep venous thrombosis and varicose veins. Why do we have varicose veins? Varicose veins are caused by the pooling of blood. So in our legs, we have in our legs we have in our legs, our calves look like that. And blood is flowing in the vein up against the gravity. Blood is flowing up against the gravity. So this blood that is flowing against the gravity, there are valves, one-way valve, to ensure that if the blood goes up and is trying to come down, it will prevent it. It will close. The veins will close to prevent the blood from flowing backward. As you get older, these valves are gonna damage. They're gonna defect due to obesity, due to pregnancy, obesity, due to career lifestyle, police officers standing long times. So that's gonna defect these veins. So that means blood is gonna start flowing backward. And it's gonna pool. It's gonna be pooling of blood. Pooling of blood. You see, that engorgement is caused by the pooling of the blood, and varicose veins are commonly caused in the lower limbs. So where do we usually find most of the blood? We find it in this is really important. Do we find our blood more on the systemic circulation, or do we find our blood more in the pulmonary circulation or inside the heart? Well, inside the heart is gonna get pumped real quick because you're not gonna have a lot of it. So only about 70% is gonna be inside the heart. But in the pulmonary circulation, it's gonna get reoxygenated and comes right back. So it makes no sense for my heart to contain a lot of blood because it is a transient phase. So the blood can get pumped out, either pumped out into the systemic circulation, or pumped out into the pulmonary circulation. So about only 7% of my blood is in my heart. In my pulmonary circulation, I do have blood, and obviously my lungs are bigger than my heart. So obviously there's going to be more blood in my lungs than in my heart. That's about 90%. But my system, my tissue, that's the winner. That's the one who's going to have most of the blood. About 84% of the blood in my body is in my tissues, in my systemic circulation. So that's comparing where the blood is. Is the blood highest in the systemic circulation, the lung, or the heart? System. Very good. Now, if I want to compare veins and arteries, is my blood more in the veins or in the arteries? Well, the question should be, I have two kinds of veins, right? I have systemic veins and I have pulmonary veins. Do you think more blood is going to be in the systemic or pulmonary? Systemic, because pulmonary is a small circle. Now within my systemic vessels, do you think there's going to be more blood on the veins or on the arteries? On the veins. That's why they call them the capacitance. Veins are called the capacitance blood vessels. These are the capacitance blood vessels. You cannot cut an artery because the artery is so deep, but the vein is superficial. That's why they call it intravenous injection. They don't call it intraarterial injection.
About the one in the thigh, that like if something happens to that artery, like bleed out in seconds, compared to like if there were injury to the vein, you'd be more likely to survive.
So injuries to the artery are usually atherosclerosis. When you have excessive lipid plaques, when you have excessive sugar, when you have deposition of material that would clog the that's going to clog the blood vessels. So that is the damage that could happen to the artery. But the artery is gonna rupture also like in an aneurysm. So in an aneurysm, if you have high blood pressure and blood keep hitting the walls or the artery, it's gonna injure. It's gonna make it like a balloon. So the artery that's supposed to look like that, and a lot of blood keep hitting the wall, This wall is gonna make it like a balloon, and blood is gonna go in here, is gonna clot, and it may rupture and cause internal hemorrhage. That's an aneurysm. That's an aneurysm. Or you can have artery that you deposit a lot of fat, lipid, tissue, or sugar. Okay? So the graph here shows the components of the blood pressure. That shows you, look at who has the most blood pressure? It is your aorta because it's right off the heart. Then you have your elastic arteries and the muscular arteries. And once you get to the capillary, now here, this purple indicates that we are exchanging, we are perfusing the tissue. We are giving the tissue oxygen and removing carbon dioxide and giving the tissue ATP. And that's going to drop, um that's going to drop the pressure in the veins and on the vena cava. Okay, this is a temporal artery, and that is a facial artery, and this is the common carotid artery. These are where my pulse sites are. We can take a temporal artery pulse. We can take a facial artery pulse. We can take the common carotid artery pulse and the brachial pulse. People usually go for the radial pulse. There's also femoral pulse. There's popliteal artery pulse, and there's a posterior tibial artery pulse, and there's the dorsalis pedis artery. This is the dorsalis pedis. So we talked about the blood pressures. These are the dangerous diseases you need to worry about. Your um, um, cholesterol plaques, your sugar plaques, like atherosclerosis, for atherosclerosis, your sugar plaques, and your lipid plaques, and your cholesterol plaques. And you see, they make the diameter smaller. They make the diameter smaller, so less blood is going to flow out. Less blood is going to flow out. Okay, there we go. We talked about this. What is that? What do these two look like? Muscles. So what is this depicting for you? I drew it right there. I think that the drawing is still up there.
Oh, that's,
Muscle, right?
We're talking about the valve that's in the middle. So what is that called?
the,
It's still
it's a
drawn.
one-way valve.
Yeah, it's a one-way valve. You see the arrow pointing up. You, you, you see with my mouse? The blood is flowing out. It's flowing out this one-way valve.
And then if it goes down, then like,
What's the disease when it goes down?
um,
This reflux when it falls backward. That is known as varicose vein. Varicose vein. I'm sorry? Yeah, that's known as varicose veins. These are damaged veins that pool. You have blood pooling, engorgement of the varicose veins. So when we are exchanging in the capillaries, what is the power that is causing the gradients of this blood flow? You have filtration pressure, so you power the movement of the blood that flows out through these fenestrations, through these holes. In the middle of in the capillary, there is no net movement, while reabsorption is when you are headed to the veins and you use osmotic gradient to reabsorb all the fluid backward. So the baroreceptor is very important to detect. The baroreceptor is very important because it's going to detect, the baroreceptor is going to detect the change in the stretch. It's going to detect the change in the stretch reflexes. So if your blood pressure increases, there are nerves, and these nerves are able to feel, they're able to feel a stretch. This stretch is going to be an input that is going to be sent into your hypothalamus to tell the hypothalamus there is a gross increase. There is a gross increase in the blood vessels. There's a gross increase in the blood vessel diameter. And this gross increase in the blood vessel diameter signifies there is high cardiac output, signifies there's high contractility, signifies there is hypertension. So an output signal is going to cause a drop. It's going to cause a drop in the blood pressure by reducing the electrical stimulation of the heart and also by increasing the diameter of the blood vessels, causing vasodilation and dropping the electrical stimulation of the heart, and that causes a compensatory, a reflexive, a drop in the blood pressure. The kidneys also participate in blood pressure homeostasis. So the kidneys, when your blood pressure increases, they will make you urinate a lot. That's known as diuresis. So you start urinating and removing the water from your blood, and that's going to drop the blood volume, and that's going to drop the blood pressure, going to drop the cardiac output, and going to drop the cardiac contractility. But if you are having low blood pressure now, the kidneys, they're not going to make you urinate. They're going to hold the water. They're going to hold the urine in order to increase the blood volume, in order to increase the blood volume and restore the homeostasis. We talked about the pulmonary, talked about the veins. Yeah, you don't need to memorize these veins. Just appreciate them, but you don't need to memorize them. Okay, so in addition to the end of the chapter, open stacks question. Okay, you guys want a study guide? Make for your study guide for next quizzes.
Is it gonna be similar to open stacks question?
Yeah, the part is gonna be similar and part is gonna be based on the study guide.
Okay.
So you have to do the study guide
Okay.
because it's gonna be really big. Yeah.
Next week is quiz 5 and 6.
Yeah, together. Yeah.
So it's strictly all together, or you
Yeah,
doing the second
25 as is gonna be lecture quiz 5, and 25 is gonna be lecture quiz 6. So it's gonna take a 1 hour. So we're gonna start 9:15, we're gonna end
Oh, I
10:15.
thought we would have 2 hours.
Yeah, so half hour for each. Even when we did the midterm, it was 50 questions, 1 hour.
Oh, yeah.
Yeah, we did.
I forgot. We did
Okay,
this.
so I'm gonna give you a study guide. So do the end of the chapter, open stacks, and do the study guide.
So 19, 20, 21, and 22.
Yeah,
Yeah,
Okay.
these 4
not
chapters.
21 though, 22. It's
19,
2022.
20, 18, 19, 20, 22.
Yeah, I gave you the announcement.
PowerPoint that says, yeah, 18, 19.
Okay.
20, 20, 22.
Okay. You don't have to memorize all these veins. This is just for you to see that we have, we talked about this left ventricle, and we talked about this aortic arch, and the first branch is your brachiocephalic, then the left common carotid, then the left subclavian. Just know those major three. Okay. And these are the lower limb vessels. So you're just appreciating them, but we're not gonna be like testing you guys on to memorize all of these blood vessels. Okay. So the last thing is we have 30 slides for the respiratory system. Okay, so the respiratory system, the main thing you need to know about the respiratory system is a continuation of the cardiovascular system. So we have hemoglobin. What is hemoglobin doing in the blood? Yes, blood is being pumped. Yes, blood is full of hemoglobin. Yes, hemoglobin is gonna reach the lung. But what is hemoglobin going? Has to be able to exchange, take oxygen from the blood, from the lung, and give it to hemoglobin, and take carbon dioxide from hemoglobin. So you can never understand the respiratory system structure and function properly without a good understanding of your hemoglobin. So hemoglobin is like Uber. It can only take an uptown trip or a downtown trip. So uptown trip is when, so an uptown trip is when we are going up to the lungs. Uptown trip is when we are headed upward to the lungs. Uptown is when we are headed upwardly to the lungs. Downward is when we are in the tissue. So the tissue has high partial pressure of oxygen. It has high partial pressure of carbon dioxide. That makes sense because the tissue has a lot of metabolic waste. It's using a lot of oxygen for oxidative phosphorylation. So it's consuming a lot of oxygen. It has low partial pressure of oxygen, and it has high partial pressure of carbon dioxide. While the lung, when you take a deep breath, you have high partial pressure of oxygen, and you have a low partial pressure of carbon dioxide. So on my uptown trip, I'm going to my lung. That means I have low oxygen, high carbon dioxide. I'm gonna get oxygen on my uptown trip. So on my uptown trip, I'm carrying carbon dioxide with hemoglobin. That is known as carbamino. Carbamino hemoglobin. And coming down, I'm carrying a lot of oxygen because the lung is saturated in oxygen. That is known as oxyhemoglobin. That is known as oxyhemoglobin. And that's going to provide oxygen to my tissue. So hemoglobin does not carry both at the same time. Hemoglobin does not carry oxygen and carbon dioxide together at the same time. So it depends on what trip. Are we heading to the lung? Then we definitely have to have a lot of carbon dioxide to give it off to the lung and pick up oxygen. If we go into the tissue, then we have a lot of oxygen, so we can give the tissue oxygen for oxidative phosphorylation and for oxidative phosphorylation and for aerobic respiration. So the major respiratory structures, we divide our respiratory system into an upper respiratory tract and a lower respiratory tract. And you guys are going to see this with the digestive system. Upper digestive tract, lower digestive tract. Upper respiratory tract, lower respiratory tract. Urinary, upper urinary tract, lower urinary tract. So there's a nasal cavity, you have the nasal cavity, and you have the oral cavity. Both of them converge in the pharynx, and the pharynx is divided into three parts. You have your oropharynx, you have your laryngopharynx, and you have your nasopharynx. So the first one is the nasopharynx, next to the nose, nasopharynx. Then you have next to the oral cavity, oropharynx. Then below that, you have your larynx, known as the laryngopharynx. Then you have your larynx, that's the voice box. Then you have the trachea. And the trachea is divided into the left main bronchus and the right main bronchus. And then you have the right lung. So the major respiratory structures span the nasal cavity to the diaphragm. So this illustration shows features of the external nose and the skeletal feature. That's the skeletal feature of the nose. That's the made up of cartilage. That's why people do surgeries and they modify that. They modify the cartilage of your nose. But if it was actual tissue, it cannot be modified. But this is just cartilage. And this is your oropharynx. You don't have to memorize all of these structures, but that is how air is going to enter into your oropharynx. These are your superior, inferior, superior, middle, and inferior concha, and between them are your meatuses, where the air is going to flow through. And that is, you see that is the first one is the nasopharynx, because it's close to the nose. The nasopharynx. Then in the middle, you have your oropharynx. Then below that, you have your laryngopharynx. The respiratory system is made up of pseudostratified ciliated columnar epithelium. We mentioned that when we were doing the tissues. We said that the epithelial tissue has mucus, mucus membrane. That is mucus membrane. So the respiratory epithelium is a pseudostratified ciliated columnar epithelium, and it has seromucous glands that provide lubricating mucus. So these are the divisions of the pharynx. The pharynx is divided into you see, oropharynx, what comes after the nasopharynx? The nose, the oral cavity, then the larynx. That's why we have nasopharynx, oropharynx, laryngopharynx.
Is that what they call the larynx, like for short?
The larynx is a separate structure, but because the pharynx is close to the larynx, they call it laryngopharynx. They call it laryngopharynx because it's close to the larynx. Okay. Epiglottis. The epiglottis is like a flap that prevents the flow of the food into your digestive tract. Otherwise, the food is going to lodge is in your trachea and is going to prevent the conduction of airflow. And this is your vestibular fold. These are your true vocal cords. So that shows us the true vocal cords and the vestibular folds of the larynx. And these are important for the production of what are the larynx important for? The larynx are important for the production of the sound. So you have the larynx, that's the top upper part. Then you have the trachea, the larynx, and the trachea. And these you see, this is the larynx, and that is the trachea. And there is a hairline cartilage that is found here. This is a hairline cartilage. And this is a tracheal tube that is formed by the C-shaped cartilage. What is the trachea made up of? Cartilage. What is the name of the tissue from which your trachea is made? That's the cartilage. And this point where you divide your trachea into a part that goes, a bronchus that goes into your right lung and a bronchus that goes into the left lung, that's known as the tracheal bifurcation. That is the tracheal bifurcation. The alveoli are the most important part of the lung. If there is a defect in the nasopharynx, the oropharynx, a defect in the trachea, it could always be replaced. But if there is a defect in the alveoli, you will need a lung transplant. There is no coming back from that. Smoking the cigarette and smoking the weed is going to destroy your alveoli. It's not rare. It's very, yeah. Oh, lung. I thought you meant the lung damage. So actually, naturally, living in New York City, industrial society, you're walking around with the combustion engine burning, and taking breath ever since you are 1 year old in the stroller, smelling the gas of the taxi. So you're initially developing lung fibrosis as you go on and on. And unless you go live with the Amish and you go live in the agricultural, in the farm, then you're gonna save your lung. But the longer you stay here with the smoke, the more your lung is gonna go through fibrosis. Yes.
Possible for us to like just eventually get used to New York air, like, evolutionary wise.
So it doesn't even affect you?
Yeah, like there's just gonna be like a group of people that.
I mean, that's severe form of trauma to adapt to. And evolution takes millions of years. If this happens, it's probably gonna happen long before cars. Cars are not gonna be there forever because the cars are running on petroleum, and petroleum is running on fossil fuel. So they take oil from under the earth and they make the car, the airplane. One time it's gonna run out, so we will no longer have airplanes. We gotta go back to riding a horse. There's gonna be no more electricity. There's gonna be no more cars. But we gotta be long dead before that. This may be like 200-300 years from now. So 200-300 years, I don't care what's gonna happen. But anyway, what's gonna happen is no more oil, no more gas. So we gotta go back to riding a donkey. What are you gonna operate the gas with? What are you gonna fly the airplane with? You need fuel. You need gas. But there's no gas.
I heard we're running out of, I think, nitrogen, what's it, no, helium, we're running out of helium. They said, that's why, the balloon companies, they're putting out the picture.
Yeah, this is known as greenhouse effect. But you have to understand that these alveoli are the units that exchange oxygen and carbon dioxide. That's why they call them the respiratory zone. Everything else, your trachea, everything else that is not alveoli is called the conductive zone. It's just trying to get you to the alveoli. Your trachea, conducting zone. Your bronchus, conducting zone. Your nasopharynx, conducting zone. Oropharynx, conducting zone. Laryngopharynx, conducting zone. Trachea, conducting zone. Terminal bronchioles, conducting zone. Then you get to the alveoli, respiratory zone. So you have one respiratory zone and a lot of conducting zone. So the alveoli are your respiratory zone, and they have macrophages. And these macrophages remove all of the bacteria that come down in your respiratory system with you breathing. So when you take a deep breath, do you think only air goes inside your respiratory tract? There is a lot of viruses. There is a lot of bacteria. There is a lot of parasites. There's a lot of smoke, a lot of toxics. So your respiratory system has a lot of mucus to trap. The mucus that is in the cilia down your respiratory system is there to catch and remove all of these infectious microbes. And also is to lubricate and moisten the air that is going through your nose and through your oral cavity. Remove all of this, moisten it, prepare the air so that it can be properly exchanged. So we don't exchange in the alveoli dirty air. We have to moisten the air, purify it, and clean it from all the dangerous infectious microbes. So in asthma, you have a constriction, a bronchospasm that causes a severe narrowing of the diameter of your respiratory vessels. So air can, just like blood, blood is a fluid, and blood is a liquid fluid, and air is a gas fluid. So for air to pass through as a fluid, it needs pressure gradient. And for blood to pass through the blood vessels, it's gonna need a pressure gradient. Also, in addition to the gradient, is also going to need a lot of diameter. So the wider the diameter, the more air is gonna come in. The wider the diameter in the blood vessel, the more blood is going to come in. So the problem that we encounter is that we have take into our respiratory system we take into some microbes, infectious organisms. These infectious organisms, they are going to stimulate the immune system to release cytokines that are gonna constrict our respiratory airways. Sometimes we take in pollen. Pollen is not a microbe. Pollen is not a parasite. Pollen is not bacteria, but still your immune system is going to detect it as a form of bacteria and it's going to cause the constriction of your blood, of your airways. And that's going to cause you to cough because air is unable to pass through your lungs. So the lung has we have two lungs. We have the right lung in the anatomical position and a left lung. Both of them have a lower oblique fissure. You see, this is known as the oblique fissure. This is the oblique fissure. And the top one is only found in the right lung. So the right lung has two fissures, while the left lung has one fissure. The right lung has two fissures, and the left lung has one fissure. The one fissure, both of them have it in the bottom. It is known as the oblique fissure. Oblique fissure. While the top fissure, is it found in both lungs? Is it found in both lungs? It's found only where? In the right lung. And that is known as the superior lobe. Not the lobe. That is the horizontal fissure. The horizontal fissure gives me a superior lobe, a middle lobe, and an inferior lobe. While the oblique fissure only gives me a superior lobe and an inferior lobe, no middle lobe.
So they're not interchangeable, like the right lung transplant.
They transplant both. You cannot transplant one and leave the other. So they transplant both. But you have to understand that it is the right lung that has two fissures and therefore three lobes, while the left lung has one fissure and two lobes. You have intercostal muscles. These are the muscles we learned in the lab. They aid in the respiration because we have a very important law known as Boyle's law. So Boyle's law says that at constant temperature, like physiological temperature, 25 degrees Celsius, in physiological homeostatic temperature, the relationship between the volume and the pressure will always be inverse. So if I want air to flow into my lungs, I have to create a gradient. So air, I have how many kinds of air do I have? I have three kinds of air. I have air in the atmosphere, air in the lung, and air in the tissue. So if I want air to come into my tissue, so on the bottommost layer, I have tissue. This tissue has a lot of cells. So here I have the partial pressure of oxygen in the tissue. Then in the middle, I have my lung. Where I have the partial pressure of oxygen in the lungs. Then I have partial pressure of oxygen in the atmosphere. And this is my head, this is my nose. Okay? So in order for air to go down concentration, it has to go down pressure gradient. Remember? To go down pressure gradient. And then we have to go down to the tissue. So, in order for this to happen, in order for air to go inside my lung and into the tissue, does the pressure has to be highest, middle, lower, or does the pressure has to be lowest, then So what is the order of pressure? Is it higher the atmosphere, then the lung, then tissue, or highest in the tissue, then the lung, then the atmosphere?
Highest in the tissue.
High, because you want to come in, right?
Yeah.
So I want air in when I'm inhaling. Inhale, air to come in. I have to make the pressure here the most, here least.
Oh, I thought you were asking for something else.
Okay, so I want to increase the pressure. So what I do is I take a deep breath. When I take a deep breath, I increase my volume. When you take a deep breath, my intercostal muscles are going to pull out my thoracic cavity, and these intercostal muscles are going to increase the transverse diameter of my thorax, and my diaphragm is going to move down. So my diaphragm is going to move down, and my thoracic cavity is going to move out. Now I have a huge box. When I have a huge box, what happened to my volume? Increased. But we said Boyle's law says at constant temperature, like homeostatic temperature, it's constant. He said at constant temperature, the relationship between volume and pressure are the opposite. So when I take a deep breath, my intercostal muscles pull out my chest, make a big balloon, diaphragm move down, make a big balloon, my volume goes up, my pressure goes down, and that's why the air moves from area of a high pressure, the atmosphere, into my lung. But when I want to expel air out, then the opposite. They're gonna press. So now the balloon is gonna get smaller. The volume is gonna get smaller because the diaphragm that was out is gonna compress my lung. Is gonna push in my lung, and my transverse diameter is gonna push in the thoracic cage, is gonna squeeze in, and that's gonna cause the air is gonna cause the pressure to be high. Because the volume went down, the pressure is gonna be high, then the air is gonna go from an area of a high pressure to an area of a low pressure. So fluid, whether blood in my heart or gas in my lungs, is only moving in an area from high pressure to area of low pressure. So that shows you Boyle's law. You see Boyle's law. Boyle's law says if you keep the temperature the same, the relationship between volume and pressure will
Volume will increase and the pressure decreases.
the relationship between them will be inverse. Inverse. So this is showing you the two circumstances.
Yeah.
But the law is if the temperature is constant, the relationship will be inverse. As you see here, volume increase, pressure decrease. Here, volume decrease, pressure only when what?
When the pressure, when it's constant.
Only when the temperature is constant. Only when the temperature in this system is constant, then the relationship between volume and pressure will be opposite. So my lung has to be encapsulated in layers, the same way my heart was. So we have parietal pleura, we have a visceral pleura, and between them is a serous sac to prevent us from damage. And there will be intrapleural pressure. So when you take a deep breath, air is gonna stretch all the way from the atmosphere into your lung to the deep corners of the base of your lung to the interpleural fluid over there. That's why there's a problem called pneumothorax when you fracture your rib and your rib like a knife cut your lung. So now all the air is liquid is gonna leak out, so air is not gonna flow inside into your lungs. So in inspiration, there we see in inspiration, the intercostal muscles contract and pull out, making the air inside my lungs a lot and making the volume big, making the volume bigger and the pressure less, and then the air is going to flow in. But look at what happened in expiration. The diaphragm push up. You look at, compare the lung here in inspiration to in expiration. Here you see the arrow push up, squeeze, make the volume small so the pressure was high like a toothpaste. Your toothpaste, you make the volume of the toothpaste small, you compress it, toothpaste come out because the pressure was high because you make the volume small. But here, if you want to fill the balloon, you stretch out, you make the volume high and the pressure low. Now, the concept of inspiratory reserve volume is how much air you can have when you, so a tidal volume is how much air you can get inside your lung and out in a normal inspiration, like when you're breathing. That's tidal volume. 500 in, 500 out. 500 in, 500 out. 500 in, 500 out. That's tidal volume. Inspiratory reserve volume. That is how much the extra, the most amount of air you can get inside the lung. That is inspiratory reserve volume. How much air you can get out of the lung. That's expiratory reserve volume. The vital capacity is the most amount of blood the most amount of air that can come out. That could be, vital capacity is the most amount of air that can enter or leave your lung at any time. But you see this purple here, that's known as the residual volume. From the name, residual volume. What does residual volume mean?
October?
Yeah, that's the residual volume. That's the air that's never getting out no matter how hard you blow out. There's still some air inside. That is the residual volume. No matter how hard you exhale, for air to get out is never getting out. And this is called spirometry. In spirometry, that's the pulmonary function test. We want to see how much air we can get inside the lung, how much air we can get outside of our lung. And this is the electrical activity that is responsible for, your muscles, they contract in order to broaden your chest and increase the volume, decrease the pressure when you're inhaling. And then they contract to compress the diaphragm and your chest in order to get the air out. How do they contract? With the nervous system. So there is a center here in your pons known as the dorsal respiratory group. And there is a center known as the ventral respiratory group. That one is going to show you exactly the procedure. I can show you, we talked about how oxygen is exchanged between you see, that's the alveolus and that's the plasma membrane. So we exchange air into the alveoli and carbon dioxide is going to flow back into the blood. Okay. You don't need to know this hyper. So we talked about this hemoglobin. It has how many subunits? 4 subunits. Each subunit has how many hemes? Each heme is attached to what? Iron. Is it +2 or +3? +2. Each iron is going to attach to what? Each heme has an iron. Each heme has an iron. Each iron is attached to oxygen. Oxygen. So this shift shows us that hemoglobin has a sigmoidal curve, and when things get worse, when it's too hot, when there is extra demand for oxygen, when it's too acidic, the graph is going to shift right. What does the graph going to shift right mean, or the Bohr shift? It means that the affinity for oxygen in hemoglobin is going to be less when your tissue is less. So for example, if your tissue has a lot of oxygen, will hemoglobin have a lot of oxygen? Yes, it has a lot of oxygen. It doesn't need to give it any. So it will have a lot of affinity for oxygen. But if the tissue is exercising, does not have a lot of oxygen, will hemoglobin have a lot of affinity and saturation for oxygen? No, this is going to give it to it. If you're broke, will your dad have a lot of oxygen and not give you? He will give you. Same thing with hemoglobin. You have no oxygen, hemoglobin will have no oxygen because it was going to give it to you. So the affinity for oxygen in hemoglobin is going to be high when the tissue oxygen high. The affinity for oxygen is going to be low when the tissue is low. If you don't have money, your mom is going to give you the money. If you have a lot of money, your mom is not going to give you the money. Same thing the hemoglobin. So that's a sigmoidal curve. It means that the saturation of hemoglobin with oxygen is low when the partial pressure of oxygen in the tissue is low. So here represent the tissue and here represent hemoglobin. So the tissue is you, hemoglobin is mom. If you have a little bit of oxygen, so does hemoglobin because it gave it to you. If you have a lot of oxygen, hemoglobin is also having a lot of oxygen. You have 100% oxygen, hemoglobin has 100% oxygen. You have 10% oxygen, hemoglobin has 10% oxygen. So what does these lines mean? It means we shift. So when things get worse, like here in acid, so what is worse? Acid pH 7.2 or 7.6? The acidity gets worse when we get lower or from 7.6 to 7.2 or 7.2 to 7.6. When you go down. So pH 7.2 is more acidic than 7.4, more acidic than 7.6. The more acidic you get, the worse it gets. So that's showing you. In addition to hemoglobin helping you, it will shift right, meaning it will help you even more. So if you need money, your mom will give you money. If you need money and there's COVID, she will give you extra money. If you need money and there's COVID and you need kidney transplant, she will give you more. So same thing, hemoglobin. If the acidity is high, if the temperature is too hot, the worse things get, the more the graph is going to shift to the right. What does it mean when the graph shifts to the right? It means that now hemoglobin is going to give you even more extra oxygen because you need even more. So look at the orange graph. The orange graph shows you at pH 7.6, if the tissue only has 20% oxygen, hemoglobin has about 60% oxygen because she gave him 40%. But when the pH was 7.2, and the tissue only has the same number, 20% oxygen, hemoglobin has only 20% because she gave 80. Last time she gave 40, this time she gave 80. Even though the saturation is the same, 20, but because the pH got worse, hemoglobin curve shift right, known as the Bohr's effect. So when things get worse, do we shift right or left? We shift right. And when things improve, do you see here the temperature? 10, what's better? 10, 20, 30, 40. What's hot? What's worse? Moving this way or that way?
Moving this way.
Moving this way. So 40 is really hot.
Yeah.
So you see hemoglobin curve is going to shift to the right, signifying what? Meaning what? Meaning that hemoglobin is now going to give even more oxygen than it would when temperature was 10 or 20 or 38. So the worse things get, the more benevolent and the more generous hemoglobin is going to be. And the better things get, the more oxygen is going to hold. He's going to have a lot of saturation, a lot of oxygen for hemoglobin because you don't need it. When you need it, it will give you. The worse you need it, the more it will give you. Okay. And fetal hemoglobin, babies have hemoglobin, adults have hemoglobin. Fetal hemoglobin is not as good as adult hemoglobin. Fetal hemoglobin hold on to oxygen more than adult. Adult, you need oxygen, give it to you immediately. Fetal hemoglobin, adult hemoglobin is like your mom. She gives you a lot of money. Fetal hemoglobin is like your dad. He will give you, but just a little bit. It's not like your mom, compared to your mom. So fetal hemoglobin has more saturation for oxygen in the times of need than would. You see here at 80, when the tissue is 80 and is missing 20, adult hemoglobin, so I'm sorry, let's look at 26. At 26,
Orange is adult hemoglobin. Hemoglobin gave you 50% of the oxygen it has. That's mom. Mom gave you 50% of her bank account because you only had 26%. But when you had 26% fetal hemoglobin, your dad gave you about only, because this is about 70, man, that means it gave you 30. It has 70 and it gave you 30. Here, mom has 50 and gave you 50. So fetal hemoglobin is worse deliverer than adult. Adult hemoglobin is a better hemoglobin giver than fetal hemoglobin. Okay. So we talked about the lower and the upper. All right. Okay. 12:43. 2 minutes left.